Now, before moving forward, let's quickly recap what we know so far. First, we understand the anatomy of the MTU, which includes the muscle, as well as connective tissues, which are in parallel with the muscle, i.e. myofascia/ECM, and in series with the muscle, i.e. tendon. We also discussed the importance of the ECM to muscle connection via costomeres, which are also referred to as adhesion complexes or transmembrane protein complexes. And we also discussed how the ECM is important for not only force transfer during muscle contractions to assist in movement, but also to help distribute forces across the muscle fibers, i.e. lateral force transmission. We discussed the connection between the muscle and the tendon, called the myotendinous junction, which is an area comprised of heavy costamere concentration, ECM collagen fibers, and of course the tendon collagen fibers. And this is where large force transfer occurs during muscle contractions. The MTJ is also the point of highest tension during a muscle contraction, especially when the opposing external force is relatively high, compared to the counteracting contractile force. Along that line, the greatest amount of tension at the MTJ site occurs especially during maximum eccentric contractions, which is a situation in which the MTU undergoes forced lengthening due to the opposing external force being greater than the maximum contractile force. This situation is also referred to as eccentric overload. In sporting situations, strains occur during high momentum situations in which there is a rapid maximum eccentric contraction and therefore a rapid rate of tension development, again, mainly at the MTJ site. Strains during these situations can especially occur when the neurosensory protective mechanism, referred collectively as the GTO, is too slow to respond to this rapid tension development or just simply fails to respond. Remember, the GTO is comprised of specialized collagen strands within the MTJ/tendon area and is highly innervated by group 1B sensory neurons. When the GTO strands undergo a rapid rate of tension development or simply excessive tension, the group 1B neurons depolarize and create electroneural discharges, aka action potentials, which go towards the CNS, which is the afferent direction. At the spinal cord, the 1B afferents will inhibit the motor neuron via inhibitory interneurons, which would decrease the signals towards the muscle for contraction, thereby causing relaxation, which in this case would be very brief and occurs for the sake of releasing some of that tension, or rather slowing down the rate of tension development. This is a feedback mechanism to again protect the muscle from damage/tear. And in the last slide, we discussed how a strain or tear to the MTU, particularly to the muscle, could impair function, which is to contract and produce force. Without proper structural arrangement of the sarcomeres and its elements, cross-bridge cycling, which is the fundamental mechanism underlying contraction, is impaired. Also, along with the ultrastructural damage to the muscle fiber, we have ruptured ECM, which also impairs force transmission and allows leakage of intracellular content out and infiltration of extracellular content like calcium in. All right, now that we're all caught up, let's go ahead and move on. Let's go ahead and discuss the next process after the muscle has undergone a strain and ultrastructural damage to multiple fibers. And of course, functional impairments are present. How does your muscle and your body in general go about repairing the damaged cells/tissues? What you may notice as we move forward, especially if you learned about the immune system in prior courses, is that much of the process to repair damaged muscle is the same as any other tissue in the body, such as the skin after you scrape or cut it. We've all cut or scraped our skin before. By imagining, at least just subjectively, how the skin immediately or acutely responds to the rupture and how it repairs itself is a great way to visualize what happens when the same type of injury occurs in muscle, a shearing injury, in this case a strain. Particularly, the first two steps of the repair process in muscle, as we will discuss here, is very similar to that of other tissues/cells like the skin. Now the third step is very specific to muscle, but conceptually the same for any other tissues. So let's go ahead and outline the muscle repair process, and keep in mind these processes occur even with exercise-induced muscle damage, like after a heavy exercise bout, but at a lower level compared to when there is a muscle strain. So, for example, the soreness we feel after muscle damage is due to the same stimuli as when we feel pain following a strain. We know the pain after muscle damage is much lower than after a strain, which should generally give you a hint that the immediate acute response to damage is the same as a strain, but just at a lower degree, because obviously there's less damage during exercise induced muscle damage compared to a strain. Exercise-induced muscle damage involves ruptures, mainly on the cellular level, so just a few fibers. So we refer to this as micro tears, whereas during muscle strains, ruptures occur on the tissue level, which means a lot of muscle cells/fibers are damaged, and refer to this simply as a tissue tear, or again, strain. Again, either way, the processes leading up to the repair of the muscle cells, whether it is during muscle damage or muscle strain, is all the same. All right, so the processes following the strain all the way up to full repair of the muscle can be broken down into three specific phases. First, we have the destruction phase, which is also described as the acute injury response. Acute, again, referring to the immediate nature of this response. As most of you know, with any damage to cells or tissues, there's always an immediate immune system response, and this is the case for muscle injuries as well. The destruction phase and the involved immune response fundamentally exist to set the foundation for proper healing of the damaged components of the MTU, namely the muscle fibers as well as the ECM that surround the muscle fibers. So during the destruction phase, first we have focal necrosis. Necrosis, as we defined earlier, is cell death in response to damage to the cell. Focal refers to the focused or centralized location of the necrosis. And in the case of a muscle strain, focal necrosis describes death of damaged muscle fibers, localized specifically to the area of the strain. It would be a very difficult situation if all the muscle cells were necrotized within that muscle tissue when there is an injury to one area of the muscle tissue. This would not end well, obviously. Therefore, the focal aspect of injury-induced muscle fiber necrosis is obviously very important, and there is a mechanism in place to ensure that the number of fibers undergoing necrosis and the area of individual fibers being necrotized are controlled and limited. And going along with that last point, focal necrosis during muscle injury can also be characterized by necrosis of only the damaged portions of the muscle fibers and not the whole fiber itself. This is because muscle fibers are structurally unique to other cells in that muscle fibers are relatively long and can run the entire length of the muscle. So oftentimes, only the damaged area of the muscle fiber undergoes necrosis and the undamaged area is preserved. Next, along with focal necrosis of damaged fibers or damaged portion of the fibers, there is also an acute inflammatory response. And this is characteristic of the acute immune response to tissue injury. In other words, immune responses accompany the process of inflammation. Not many people understand inflammation and know the difference between acute and chronic inflammation. In other words, good and bad inflammation. In this case, we have acute inflammation, which is a very normal process following injury. Inflammation gets a bad rep because of the stigmas associated with the term inflammation, since most people associate that with disease, pain, and poor health. So in this section, I'm going to clear up some misperceptions regarding inflammation and help you understand the purpose of acute inflammation following injury and why it is a necessary evil, so to speak. Now, during this phase, we also have a cleanup process of cellular debris resulting from focal necrosis, which include the degradation of necrotic fragments. So basically, the cleanup of dead cell fragments. Now, at the end of the destruction phase, we have the initiation of healing and thus the repair phase. The repair phase involves two processes of healing which occur concomitantly together. These include regeneration of muscle fibers as well as scar tissue formation. Here we will also discuss misperceptions associated with scar tissue, since like inflammation, it sort of has a negative stigma associated with it. I will discuss why scar tissue is critical for muscle repair and in what situations scar tissue formation can have a negative impact, as I've alluded to earlier. Now, with that, we will discuss the importance of regeneration to scar tissue formation ratio and how this ratio would impact the overall quality of healing and therefore repair of the muscle. We will also discuss the terms structural and functional healing or recovery and the differences between these two. Next, we have the final step of muscle repair, which is largely impacted by rehabilitative interventions. This phase is called the remodeling phase, which, as the term implies, involves the remodeling of the muscle architecture at the damaged sites. Not only does the muscle undergo remodeling back to its normal form, but also other components of the MTU, including the ECM and the connections to the ECM, and of course other tissues like blood vessels to restore perfusion, as well as neurons to restore neural innervations to the damaged muscle. And during this phase, the goal is to restore the structural integrity of the MTU as well as its functional capacity, i.e. strength. And this is especially critical for athletes. All right, so we got the destruction, repair, and remodeling phases. Let's go through each one in detail. So first, the destruction phase. This is the phase immediately following rupture of the muscle. And this particular portion of the destruction phase, as explained here, will persist to about 12 hours post-injury. And of course, this time frame will depend largely on the severity of the strain, in that the greater the severity, the longer the destruction phase, in addition to the subsequent phases. Now, as I briefly outlined in the prior slide, the initial process is the focal necrosis of damaged fibers, in particular, the damaged segments of the muscle fiber. And this is largely mediated through catabolic reactions. Catabolism refers to biochemical reactions that break down molecules into their smaller constituents. In other words, catabolic reactions causes molecular degradation. So what type of molecules are being degraded within the damaged portions of the muscle fibers? Well, although muscle cells are primarily made up of water molecules, it is also majorly dense with proteins. This is because proteins are integral to the structure as well as function of muscle cells. So the major molecule that undergoes degradation during focal necrosis is protein. So during the initial destruction phase, there is elevated myofiber protein degradation. Other terms to describe protein degradation include protein catabolism and proteolysis. A biochemical reaction ending in lysis refers to a degradation process. So as the proteins within the damaged fiber segments are being degraded, these fiber segments eventually die, i.e., they undergo necrosis. They are necrotized, in other words. Again, this can occur on the entire fiber or just portions of the muscle fiber, depending on the severity of the damage. So what signals this increase in myofiber protein degradation upon damage? Well, one of the major stimuli for protein degradation is an excessive influx of extracellular calcium. Remember, previously I mentioned that when muscle undergoes a strain and fibers are severely damaged, there is an increased infiltration or influx of extracellular calcium, meaning calcium that exists outside of the muscle cell is now infiltrating the damaged area of the muscle cell, largely because of the ruptured ECM and sarcolemma, which is again the myofiber membrane. Now, this elevated presence of calcium within the muscle fiber is stimulatory to specialized enzymes that are responsible for catalyzing proteolysis, or again, protein degradation. These enzymes are collectively referred to as proteases. And the proteases that are activated in response to elevated calcium influx is described as calcium activated proteases. And with this increased proteolytic activity, the muscle fiber proteins are degraded, eventually killing the damaged portion of the muscle fiber. Now, in addition to calcium, other factors also contribute to this elevated protein degradation and the ensuing necrosis. And these include inflammatory cells that leak into the damaged area passively due to ruptured blood microvessels, meaning these inflammatory cells are not recruited to this site. Rather, they just simply leak into the damaged area. Now, this is not necessarily the acute inflammation I briefly introduced in the last slide, but rather it is something that partly contributes to the initial proteolysis and subsequent necrosis of the damaged portion of the muscle fibers. These inflammatory cells release highly reactive molecules called free radicals, of which the major free radical are reactive oxygen species, ROS. These are molecules that react with other molecules, causing those molecules to destabilize and eventually degrade. These free radicals therefore contribute to the degradation of intramyocellular proteins. In addition to these free radicals, these inflammatory cells that have leaked into the damaged area also release their own proteases, which, as we know, will catalyze proteolysis, protein degradation. So more degradation of intramyocellular proteins. Altogether, the greater the rupture, the greater the infiltration of inflammatory cells, and thus greater degradation and necrosis. So this particular process that is in addition to calcium-activated proteolysis is referred to as injury amplification. And there are acute treatment strategies to help minimize this injury amplification and thus excessive necrosis. And this mainly involves icing. So more on this mechanism in our next lecture series. So as we said, the necrosis that the damaged muscle fibers are experiencing is focal, meaning it is localized to only the damaged area of the fibers. Of course, if the majority of the fiber is damaged, likely the entire fiber will be necrotized. This is again dependent on the severity of the strain. So within individual muscle fibers, how is it that only the damaged areas are necrotized and not the remaining undamaged areas? Well, during this destruction phase, as the damaged fiber undergoes degradation and necrosis, new plasma membranes form along the edges of the undamaged portions of the muscle fiber. These are referred to as contraction bands. These contraction bands essentially protect the undamaged portions of the muscle fiber from degradation and necrosis. So when the contraction bands are formed, the muscle fiber forms identifiable segments or zones as illustrated in this figure. In this figure, we have a very simplified example of damaged fibers following a strain injury. Here we have 5 individual fibers within the area of the muscle that experienced the strain. So imagine these are fibers somewhere near the MTJ. Of course, with most strain injuries, more than 5 fibers would be damaged. I'm just using 5 fibers here to provide a more simplified illustration. So as shown here, these 5 fibers were damaged. They were ruptured due to excessive tension. So this entire middle segment is where the muscle fibers were damaged and essentially torn apart. As I mentioned earlier, the damaged portion of the muscle fiber will undergo necrosis, and we are left with necrotic fragments, which are again dead pieces of the fiber. The segment of the fiber that is necrotized is referred to as the regeneration zone, indicated by this RZ here. Now, during this initial destruction phase, the regeneration zone only contains dead pieces of the muscle fiber, but obviously the term regeneration in regeneration zone alludes to the fact that this is the segment where muscle fiber regeneration is going to occur eventually. However, during the initial destruction phase, the regeneration zone is simply the necrotic segments of the muscle fibers. And the regeneration zone, as it experiences necrosis, expands laterally as necrosis proceeds. So what protects the undamaged area of the muscle fibers? As I indicated earlier briefly, new plasma membrane, aka contraction bands, form and protect the remaining undamaged portions of the muscle fiber from degradation and necrosis. You can imagine this membrane forming right along here and here. And this membrane would separate the regeneration zone from what is called the surviving zone, which contains the undamaged portion of the muscle fibers. So the contraction bands essentially help preserve the muscle fiber and prevents excessive or unnecessary degradation and necrosis. This is why the necrosis following a strain is described as focal. It is controlled and limited to just the area that was damaged. So if I asked on the exam which of the following mechanisms ensure focalized necrosis and protects undamaged portions of the muscle fiber, it would be the formation of contraction bands or plasma lemma along the edges of the undamaged fiber segments. Now, these undamaged segments of individual muscle fibers are also referred to as fiber stumps. So make sure you remember that term, fiber stumps. So all these are fiber stumps. I will use that term continuously throughout this lecture. So for fiber number 1, here we have one fiber stump and another one here. And again, same goes for the other fibers as well. Now, in between the adjacent fiber stumps and regeneration zones, we have the central zone, as indicated by this CZ abbreviation. This is the area of the ruptured fibers that is filled with blood, mainly due to ruptured microvessels, aka capillaries. Blood collecting outside of the blood vessel is referred to as a hematoma, which is a technical term for simply bleeding. We of course see this every time we accidentally cut or scrape our skin. We know that a hematoma forms, i.e. we bleed, because capillary vessels were ruptured as well. So usually in the middle of the tear or rupture of these muscle fibers, a hematoma would form. Of course, if this hematoma is large enough because the strain and therefore the tear was severe, this would present on the surface as a large bruise. The bruise is the hematoma in the muscle. So the central zone, as shown here, is in the middle of the ruptured fibers, so in the middle of the fiber stumps as well as the regeneration zones. And as I said, is largely filled with a hematoma, which will eventually clot due to clotting factors released mainly by blood platelets. And the clotting is to simply help prevent further bleeding. Platelets are not necessarily cells, but cell fragments that circulate in blood that are responsible for forming blood clots, especially when a hematoma forms. And this occurs via clotting factors, which include molecules like prostaglandin and thromboxane. Now, just as a side note, so we are familiar with terminologies, the formation of blood clots is referred to as thrombosis. Thromboxane is also responsible for platelet aggregation, which is a process by which platelets adhere to one another to essentially put a band-aid on the ruptured blood vessels. It is in a sense a plug to stop further hematomas. So in summary, platelets stop further hematoma in the central zone by plugging up the blood vessels that were ruptured, as well as clotting the hematoma. So upon a muscle strain, we will have multiple muscle fibers, particularly around the MTJ, that would resemble what is illustrated here. We will have surviving, undamaged segments of muscle fibers within the surviving zone, which is protected from necrosis via contraction bands, which is a plasma lemma membrane. This separates the damaged segments undergoing necrosis, and that is within the regeneration zones. And in the middle of it all, we have the central zone, which is during this phase filled with the hematoma and eventually a blood clot. Now, as described in the last bullet here, we know that a muscle strain often presents acutely with swelling, aka edema, around the site of rupture. This swelling is due to a couple major factors. One, the ruptured fibers will leak intracellular water. And since muscle fibers are 80% water, rupture of all these fibers will result in intracellular water leakage, which would result in swelling. Secondly, when blood vessels rupture, there is a change in pressure within those blood vessels. Specifically, the area of the rupture in the blood vessels will now have a lower pressure than within undamaged blood vessels. This high to low pressure gradient will drive blood towards the ruptured site and therefore contribute to edema. In addition, some factors released during the destruction phase stimulate the dilation of blood vessels, also known as vasodilation. This will also increase blood flow to the ruptured site and contribute to swelling. Now, we will talk about swelling in the next lecture series in more detail. However, swelling is something that is often dealt with immediately upon a strain. This is because edema is associated with greater hematoma formation and could widen this central zone and expand the area between the surviving zones, which would not be favorable for subsequent repair. Now, the two modalities to minimize swelling after a strain is icing and compression, as well as elevation. And many of us generally know this. Like I said, we will discuss the purpose and mechanisms underlying these acute treatment strategies in our next lecture series. But generally, icing in the context of what we're discussing here is used to stimulate vasoconstriction of blood vessels through a thermostimuli to equalize the pressure gradient so that blood flow is less directed towards the rupture site. And compression is used also for the same reason. It is to manually compress blood vessels to equalize pressure to help prevent excessive blood flow to the rupture site. This would aid in minimizing hematoma formation and area in between the surviving zones, the central zone. This is alluding to the fact that the closer these surviving zones are to one another, the better quality healing we can achieve. Let's think about this in the context of a skin laceration. When we cut our skin severely, in the middle of the undamaged skin, we have a hematoma. And of course, although we can't see it with the naked eye, there is necrosis occurring. So what do we do to acutely address this laceration? First, we stop the hematoma. We compress the rupture site and also use methods to constrict blood vessels and to accelerate blood clotting. Now, after this is addressed, what is usually the next procedure? We apply stitches. And we generally know stitches are used to close up the rupture. So why do we do this other than to protect us from infection? Stitches are used to minimize the central zone, to bring the surviving zones closer together. And this is to help facilitate healing, which is essentially the process of reconnecting the surviving zones of the skin. So obviously, in the case of a muscle strain and rupture of muscle fibers, we can't apply stitches since it is under our skin. So the only thing we can do to minimize this central zone is to prevent excessive hematoma formation by reducing edema. Okay, so as I said, more on acute treatments to muscle strains in the next lecture series. I just wanted to introduce this concept here since it is related to the destruction phase. Now, one important type of cell that hasn't been discussed much in this lecture that can be affected during a strain are nerve cells, also known as neurons or nerve fibers. The specific type of neurons that innervate skeletal muscle and are responsible for stimulating muscle fiber contractions are called motor neurons, more specifically alpha motor neurons. And contraction through these neurons occur through a process called excitation-contraction coupling, or EC coupling for short. During a muscle strain, also depending on the severity of the strain, motor neuron denervation can occur. Denervation simply describes the disconnection between the neuron and the cells it's supposed to connect to. Now, if we look again at this simple illustration, the side on which the motor nerve is located in relation to the central zone of the damaged muscle fibers is described as the adjacent side. On the adjacent site, the motor neurons that innervate any muscle fibers within the surviving zone remain innervated. It remains connected, and EC coupling and therefore muscle contraction can still occur here. Remember, the surviving zone contains undamaged and unnecrotized portions of the muscle fiber. This again means that EC coupling and thus contraction can happen in this segment of the muscle fiber on the adjacent side, the side of the motor nerve. However, any motor neuron that innervates a damaged and thus necrotic portion on the fiber on the adjacent side will be denervated. It will be disconnected. This occurs because the neuromuscular junction, which is where the neuron connects to the fiber, is damaged due to the rupture itself or destructed due to necrosis of this fiber segment. So in summary, adjacent surviving zone innervations remain intact, while adjacent regeneration zone innervations become denervated because this segment of the fiber, including the neuromuscular junction, is degraded. Now, when a motor neuron projected from the motor nerve on the adjacent side crosses over the central zone and innervates muscle fibers on the abjacent side, the AB-adjacent side, that neuron is completely denervated, even if innervating the undamaged muscle fiber in the surviving zone of the abjacent side. This is not because of anything related to the neuromuscular junction, but rather because as the MTU is ruptured at this location, so is the motor nerve fiber. In simple terms, this motor nerve fiber is severed, and thus motor signals to contract the muscle fibers cannot reach the adjacent muscle fibers. And of course, if the motor neuron innervated any segment of the fiber that has been damaged or necrotized on the adjacent side, there will be denervations due to the destructed neuromuscular junctions. So in summary, 1. Undamaged portions of the muscle fibers in the adjacent surviving zone remain innervated. 2. Damaged and necrotic portions of the muscle fibers in the adjacent or abjacent regeneration zones are denervated due to the destruction of neuromuscular junctions. And 3, undamaged portions of muscle fibers in the abjacent surviving zone are denervated because of a severed nerve fiber that originates on the adjacent side. So with these denervations, especially with high-grade strains, which would accompany high amounts of denervations, how would muscle function be affected? It would obviously be impaired, but why? Think about EC coupling. If there is denervation of motor neurons, nerve signals that are responsible for contractions would never reach the muscle fibers that are denervated. This would in turn reduce the overall strength or force generating capacity of the injured muscle. So far, we discussed 2 factors that would impair muscle function with strain or injury. First, it was ultrastructural damage, which would impair cross-bridge formation between the myofilaments and thus contraction would be impaired. Secondly, as just described, denervation of motor neurons would impair contraction by disrupting the nerve signals from the CNS that would stimulate muscle contractions. This is all irrespective of pain, which is alluding to the third factor that impairs muscle function with the strain. All right, so now continuing on with the destruction phase, 24 to 48 hours post-injury, roughly, we have the inflammatory response, also known as acute inflammation. Acute, again, referring to the immediate and temporary nature of this inflammation. Keep in mind, this is a normal process following any tissue injury, just like when you cut your skin. So what makes inflammation inflammation? Inflammation is characterized by the active recruitment, and that's the key word there, recruitment of inflammatory cells, also known as immune cells. In the case of tissue injury, as during a muscle strain, we describe these immune cells as inflammatory cells because they are actively contributing to inflammation. Now, of course, keep in mind, this is again acute inflammation. So the recruitment of these inflammatory cells to the ruptured site is acute, not chronic, meaning it comes and goes. So first, how are inflammatory cells actively recruited to the rupture site? In order to recruit these inflammatory cells to a particular location, there needs to be some kind of signal sent out. These signals are largely in the form of cytokines, which are a type of signaling molecule or chemical, much like hormones are. The specific type of cytokines that attract circulating inflammatory cells are called chemokines, and they are described also as chemoattractants. They serve to attract inflammatory cells to a particular area. This means that these chemokines must be released by things local to the rupture site on the muscle. And this is true. Cells that reside within the muscle cells, otherwise known as resident cells, as well as the damaged muscle fibers themselves, release a host of chemokines. And in the notes section of your PowerPoint on this slide, I've listed some examples. Overall, there is a massive release of these chemoattractants/chemokines around the ruptured site, which attracts or recruits inflammatory cells to that area. Also, I mentioned earlier that upon rupture, inflammatory cells circulating in the ruptured blood vessels can leak into the damaged area. These initial inflammatory cells can also release these chemoattractants to recruit more inflammatory cells to the site. Now for the second question, what are these inflammatory cells? The two major ones are neutrophils and M1 macrophages. These should be somewhat familiar terms to you all since you have all taken a basic human physiology course. Neutrophils are a type of white blood cell or leukocyte, and these specific cells are considered the first responders anytime there is cellular damage, as with the strain, or when there's a foreign invader like a virus or bacteria. So in the case of a muscle strain and myocellular damage, the neutrophils are the first to arrive, and this is unofficially the beginning of acute inflammation. Now, following closely to the neutrophils are prominent immune cells called macrophages, particularly M1 macrophages, which we will describe further shortly. The macrophages not only circulate in blood, but also reside at the muscle as well, so both are recruited to the ruptured area. In the initial acute inflammatory phase, these two inflammatory cells serve really the same function and purpose, and that is to clean up the mess left from cellular damage and the subsequent focal necrosis of the damaged portions of the muscle fibers. In other words, they are there initially as a cleanup crew to remove the necrotic debris. In addition, the macrophages also break down the blood clot that formed previously from the hematoma within the central zone. And the way these cells do this is through a process called phagocytosis. Now, I'm not going to go into a whole lot of detail on the process of phagocytosis, but generally speaking, it's a process by which the membrane of these inflammatory immune cells engulf these necrotic particles and degrade them inside the cell through a digestion process otherwise described as lysis. So yes, more proteolysis along with other catabolic reactions occur during this digestion process inside of these inflammatory cells. As a result, the cellular debris within the regeneration zone and the blood clot within the central zone are cleared out. Now, as an important note here, during the process of necrosis and the subsequent phagocytosis, the basal lamina, which as we know is the fine ECM layer on top of the myofiber membrane, the sarcolemma, is left unperturbed. The only part of the basal lamina that was perturbed would be the part that was ruptured. But the basal lamina is not affected by necrosis or phagocytosis. So what this means is that the basal lamina, as illustrated here in the regeneration zone, is left intact. And please keep in mind that I simplified this figure even more, and I'm focusing on a single muscle fiber now, not 5 like in the previous slide. So this is a single muscle fiber in this illustration, again, just for simplification. Now, the reason why this is important regarding the basal lamina being intact is because the basal lamina will serve as the scaffold on which the muscle fiber will regenerate or rebuild. In other words, the basal lamina here in the regeneration zones is where the muscle fiber remodeling will start. and they will serve as the foundation for muscle fiber regeneration. So if you imagine this in a three-dimensional perspective and look at it from a cross-sectional view, muscle fibers regenerate starting from the outer edge underneath the basal lamina, and from there it regenerates inward. From this two-dimensional view as shown here, you can imagine the fibers regenerating starting from here on the edges and ending here, somewhere in the middle of the regeneration zone. And of course, as I will show in the next subsequent slides, the regeneration will occur from outside inward towards the central zone. More on that in a bit. All right, so here's a very important piece of information, so take careful notes. In direct correlation with the severity of injury is the degree of acute inflammation. Thus, with greater severity, there is greater inflammatory response in that there will be a larger recruitment of inflammatory cells as described here. One important detail is that these inflammatory cells, although primarily engaged in phagocytosis and debris cleanup, can also release chemicals that promote lysis or degradation. This was briefly explained previously with the initial leakage of inflammatory cells right upon rupture. These chemicals/molecules include free radicals and proteolytic enzymes, which promote degradation of proteins and protein structures like those found in muscle. So with excessive inflammation, like with a severe injury to the muscle, there will be elevated levels of free radicals and proteolytic enzymes released by the inflammatory cells. This rise in free radical levels is specifically described as a state of oxidative stress, since free radicals are highly reactive molecules in that they oxidize other molecules like proteins. Free radicals oxidize other molecules by pulling off their electrons, rendering those molecules unstable. And when this occurs at a higher level, in that there is high oxidative stress, there will be increased cellular degradation, since these molecules, like proteins that make up the cells, are being destructed. So all in all, when there is excessive inflammation, there is a greater level of degradation, and sometimes this degradation can exceed the regeneration zone, meaning degradation can occur within the surviving zone, which is intended to be protected. This is because these free radicals and proteolytic enzymes in very high amounts can degrade that plasma lemma membrane, aka contraction bands. And again, these contraction bands were formed to preserve the undamaged area from necrosis. So when there is further degradation within the surviving zone, there is further necrosis. And this expands the regeneration zone and central zones, and thus the space in between the fiber stumps. Essentially, the wound gap gets bigger and bigger. And with that, as I previously mentioned earlier, there will be delayed repair and an increased risk for poor quality healing, which I will define later. But I am alluding to fibrosis. And this is again because there's a larger gap between the fiber stumps. More on this later. So although the acute inflammatory response to injury is necessary and a normal process, excessive inflammation can cause further damage beyond from the injury itself, and thus impair the subsequent repair of the muscle. This further damage caused by excessive inflammation is referred to as secondary damage, and is again largely mediated by oxidative stress/free radicals and increased levels of proteolytic enzymes. This means, especially with severe strains, strategies to control and limit the acute inflammatory response are critical to limit this secondary damage. Now keep this in mind, there is no way to totally eradicate inflammation. This would be impossible, at least through practical measures. And like I said, the acute inflammatory response is normal, but excessive inflammation, although normal as well, can be further damaging. So over the many years of research in sports medicine, we have developed various modalities to help limit excessive inflammation during this acute post-injury phase to limit secondary damage on healthy, undamaged portions of the muscle fibers. Now, although we will discuss these acute treatment modalities in the next lecture series, what strategies do you think are used to limit this excessive inflammation? One way is through the application of ice. Ice, as you can tell, is very versatile in the acute treatment phase. As we said earlier, ice is used to also limit hematoma formation, but it is also utilized as an anti-inflammatory measure. Again, this is not to totally eradicate inflammation, which I said is impossible, at least practically speaking, but rather to limit excessive inflammation for the purpose of limiting excessive degradation of surviving zone segments, and to minimize the wound gap, or the gap between the fiber stumps. As you may have guessed, that would help the subsequent healing and repair processes. Like the example I provided earlier with the skin wound, stitches are used to bring the severed ends closer together to help minimize the wound gap between undamaged skin to help facilitate healing, in particular, quality healing. As I said, I will define quality healing in a moment. In the case for muscle strains, we obviously can't apply stitches, but what we can do to minimize this gap, at least in the immediate post-acute injury phase, is to control excessive inflammation and thereby excessive secondary damage on the surviving zone segments. Now, just as a side note, as indicated in the last bullet, when this excessive inflammation is perpetual and aberrant, meaning it's abnormal, this is a condition called chronic inflammation, which is associated usually with the disease state. Chronic inflammation is when there is excessive inflammatory cell recruitment and release of destructive inflammatory chemicals and free radicals all the time, hence the term chronic. This is not normal. So conditions like rheumatoid arthritis is a chronic inflammatory disease. It is characterized by abnormal chronic inflammation and oxidative stress, of course, of the joint tissue. And with that, over time, the joint tissues are degraded. So what we are talking about here is not chronic inflammation. We are talking about acute inflammation, which again is normal and is temporary. It's acute. This means it will subside eventually. Excessive acute inflammation is also normal, but can be controlled and limited to minimize secondary damage and to aid in the subsequent healing process by minimizing the wound gap as much as possible. Alright, so let's summarize the initial acute inflammatory response that occurs within the destruction phase, just to make sure we're all on the same page before moving forward. Now, one way I like to describe this acute inflammatory response is that it is a necessary evil. And this has a lot to do with the fact that inflammation is causative of the pain or soreness that is experienced after the injury. But at the same time, it is also a necessary process to stimulate healing. And in the next slide, we will discuss that mechanism, but for now, understand that during the acute inflammation phase, there is pain, and the degree of pain is directly correlated to the degree of inflammation, which in turn is directly correlated to the degree of strain. Therefore, the greater the strain severity, the greater the pain. I'm sure I didn't have to emphasize that point, but mainly I just wanted you to understand that it is the inflammation that connects the injury to pain/soreness. And as many of us know, the pain is most severe around 24 hours post-injury, which is when the inflammatory process is in full swing. Although with greater severity, the pain or soreness can occur within minutes because the inflammatory process is much greater and occurs at a much faster rate. So if we examine the three general roles of inflammation after the muscle undergoes injury, the first is related to pain, which is technically described as the process of nociception. Nociception is the process by which the sensory nervous system encodes noxious stimuli or pain stimuli, leading to the perception of pain. Again, a noxious stimuli is a pain stimuli. And in the next slide, we will go over the various noxious stimuli that is present during this acute inflammation that provokes nociception, aka pain. Now, this pain or soreness following a muscle strain represents the evil in the description of acute inflammation being a necessary evil. It's something that we don't desire because it causes discomfort and physical limitations. In fact, beyond the actual damage to the muscle fibers and denervation of motor neurons, the major limiter to physical/muscle function after a strain is the sensation of pain. So we describe this pain as evil, but why is it necessary? You see, many people believe pain and healing/repair are on opposite ends of a spectrum in that they oppose each other, where in fact pain is supportive of repair. Again, I'll say that again. Pain is supportive of repair in the context of a muscle strain. How? Well, because in biological organisms, at least in humans, pain exists as a protective mechanism. Let's think about this practically. When you strain your muscle or experience sunburn or scrape on your skin, what does that subsequent pain prevent you from doing? It prevents you from perturbing the tissue and therefore cells that are damaged. Why? Because by perturbing injured tissues, you can cause more damage. Let's look at it from a muscle strain perspective. What caused the strain? Excessive tension, right? So, what does pain prevent you from doing? It discourages you from placing tension on the injured muscle. We all know when we use the injured muscle by contracting or stretching it, it's going to hurt. This is why it's undesirable to use the muscle that has been injured. Okay, so more on pain in the next slide. Also, in this first bullet, we have some details that we really didn't go into, but just to mention, part of acute inflammation is to minimize infection brought on by foreign invaders like microbials or bacteria. But given that a muscle strain is not really exposed to the external environment since it is subcutaneous and thus protected by the skin, this function of inflammation is not a huge concern during a muscle strain. It would only be if, say, the skin covering the muscle was also ruptured, which only really happens with deep lacerations, but not so much with strains. Okay, so another reason inflammation is necessary is that it is the process that precedes repair. As we mentioned in the prior slide, during the inflammation process, necrotic debris as well as the blood clot is removed, freeing the space in between fiber stumps of waste materials. This means inflammation sets the groundwork for the subsequent repair process. In addition, inflammation through various chemical signals stimulates the process of repair through the process of healing, which we will define shortly. So as you can see now, the acute inflammatory response to muscle strain is evil in the sense that it causes pain. But as you can see, it is definitely necessary. And just to allude to future topics on pain remedies that target inflammation specifically, a question that we want to ask is, could reducing this inflammatory process for the sake of pain relief actually be counterproductive to repair? Since, as I mentioned, inflammation is required to set the groundwork and stimulate repair. This is a question we will need to discuss, particularly in our next lecture series. Now, here we describe the roles of the inflammatory cells that are recruited during the acute inflammatory response. Again, we have the first responders called the neutrophils. As I mentioned, they are recruited actively through chemokines or chemoattractants. These chemokines, as listed here, are examples, and they are primarily released by the damaged muscle fibers as well as resident cells, such as fibroblasts and resident macrophages. These are non-muscle cells that reside in the muscle. The neutrophils are responsible for the initial phagocytosis of necrotic cell fragments to clean up the regeneration zone, and they also release free radicals and proteolytic enzymes to help further degrade these fragments. However, as I said, with severe injury and excessive inflammation and excessive neutrophil recruitment, this can lead to oxidative stress and excess degradation of muscle, especially within the surviving zone, which again is not desirable for the sake of quality repair. Now, accompanying the neutrophils are macrophages. More specifically, signaling molecules like the two listed here, TNF alpha and interferon gamma, stimulate the conversion of monocytes to macrophages. This is the process of differentiation, meaning the monocyte, which has no specialized function, is turned into a macrophage with a particular function. Now, to program the specific function that is required of the macrophage, we have the process of polarization, specifically M1 polarization, which programs the macrophages to complete certain tasks, which, as I described earlier, is phagocytosis of necrotic cells and blood clots, further clearing out the regeneration zone as well as the central zone, which again is the space between the fiber stumps in the surviving zones. Lastly is a topic we will discuss towards the end of the lecture. Macrophages, eventually, are partly responsible for initiating the regeneration of muscle fibers, which involves the reconstruction of muscle fiber components, like those within the sarcomeres, to eventually restore the function of the damaged muscle fibers. So I hope by now, with this information, you can understand why the acute inflammatory response following a strain is a necessary evil, and that inflammation stimulates both pain as well as repair, since pain is supportive of repair, not counterproductive to repair. Okay, as I said, let's talk more about pain, and this will be something we cover throughout this entire semester, but let's start with the basic mechanisms. We already understand the fundamental purpose of pain following injury, which is to protect the injured tissue from perturbation, given its vulnerability, of course. But how does muscle injury connect to pain? What is the intermediary? The factor that connects injury to pain is primarily inflammation, so that when you begin to feel that pain or soreness following a muscle strain or even exercise-induced muscle damage, that is an indication that there is inflammation. Now, sometimes, as we know, with low-level strains or with exercise-induced muscle damage, the pain, often referred to as soreness rather, occurs in a delayed fashion, usually around 24 to 48 hours later. This is often described as delayed onset muscle soreness, or DOMS for short. So why is it delayed during these light injury or muscle damage circumstances? Well, because as we highlighted earlier, significant inflammation does not occur right away upon injury. It takes roughly 24 hours. Now, of course, with severe strains, the pain can occur almost right away within minutes to just a few hours after injury. And that is because, as I said before, with greater severity of injury, the greater inflammatory response, which means inflammation occurs quicker, and thus pain occurs quicker and likely more severe. Now, here's one important piece of information I need you to understand. This pain that I'm discussing is not referring to the immediate sharp pain as soon as the strain occurs. That pain is due to the actual tearing of the muscle. The pain I am referring to is the after effect of the injury that is stimulated by inflammation and is often described more accurately as soreness, since it is a persistent, dull pain that is only exacerbated when there is some type of perturbation to the injured muscle. Let's think of it this way. When you accidentally touch a hot stove, you immediately feel sharp pain. This is the same kind of mechanism underlying the sharp pain as soon as you tear your muscle. Now, after a few minutes of burning your hand on the stove, your hand now has a persistent pain to discourage you from using the hand and perturbing the damaged skin. This is the same mechanism as the delayed pain I am talking about here with muscle. The soreness, the pain that is associated with the acute inflammatory response. The noxious stimuli for the immediate sharp pain right when you strain your muscle is different than the noxious stimuli for the soreness you feel, say, 24 to 48 hours later. So let's discuss. As shown in this figure, during the acute inflammatory response to the strain, there is a host of chemicals that are released from the recruited inflammatory cells, as we discussed earlier, as well as the damaged muscle fibers themselves. Some of the more prominent chemicals/molecules are listed here. We can see chemicals released from the damaged muscle fibers, as well as chemicals released by inflammatory cells. Now, all these different chemicals released during inflammation have the primary role of coordinating the inflammatory process, as well as setting the groundwork for healing and to stimulate healing, as shown in this figure. But they also can stimulate nociception, or pain, when their levels exceed a particular threshold that will stimulate sensory neurons responsible for nociception. It makes sense that the same chemicals that are released during inflammation stimulate healing as well as pain at the same time. Why? Because as I emphasized earlier, pain is a process supportive of healing, with its role in protecting the injured tissue/cells. So how do these chemicals as listed here become noxious stimuli? How do they stimulate pain signals, or in other words, nociception? Surrounding muscle, there is a large body of sensory neurons, which I mentioned are also referred to simply as afferents, since they send nerve signals in the afferent direction towards the CNS. Many of these sensory neurons are what we call nociceptors, which are sensory neurons responsible for detecting noxious/pain stimuli and converting that stimuli to a nerve signal towards the CNS, where nociception, or the perception of pain, is generated. These nociceptors at its terminal or ends, as shown here, express a variety of receptors that can detect various stimuli. These receptors are generally mechanoreceptors, thermoreceptors, and chemoreceptors. Mechanoreceptors respond to mechanical stimuli, which comes from mechanical changes to the tissue of which the neuron innervates. So, for example, when you apply pressure or stretch to the muscle, these mechanoreceptors detect these mechanical changes and provide the brain the signals necessary for us to sense that there is some mechanical changes occurring in the muscle. Thermoreceptors detect temperature changes. They respond to cold and heat and allow us to sense changes in temperature at the site the neuron innervates. Lastly, there are chemoreceptors, which detect the presence of particular chemicals. Now, keep in mind, in order for any stimuli, whether mechanical, thermal, or chemical, to become noxious or pain inducing, they need to reach a certain threshold. For example, when you stretch a muscle, you can sense the mechanical changes. You can sense stretch. But when that stretch and thus mechanical stimuli reaches a certain threshold, like when you reach the end of your range of motion, that mechanical stimuli becomes noxious and pain is induced. We all know eventually as you stretch too far, it eventually starts to hurt. This is the same with thermostimuli as well. We know that when we put our hands on something warm, we sense the temperature change. But if we turn up the temperature, that thermal stimuli, once it exceeds a threshold, can become a noxious stimuli, and that thermal sensation turns into pain sensation. The same principle applies to chemostimuli. During a muscle strain and the ensuing inflammatory response, these chemicals, as listed here, are present around the injury site in very, very high amounts. The chemoreceptors on the nociceptors surrounding that area of injury will detect these chemicals as the chemicals interact with their respective chemoreceptors on the ends of these nociceptors. And keep in mind, each chemical interacts with specific chemoreceptors. When the level of these chemicals reaches a particular threshold, they become noxious. They become a noxious stimuli. They will cause reactions at the receptor that would depolarize the nociceptor neuron, and action potentials or electrical discharges are produced, and this is denoted by this lightning bolt. These electroneural signals propagate towards the CNS, as you see here. There, particularly in the brain, these signals are encoded and pain is perceived. And this pain presents itself as soreness. This again is the process of nociception, and fundamentally it occurs during inflammation to protect the injured muscle from any further stress, since pain averts us from perturbing or using the injured muscle. You can think of this pain as a biological stop sign. You can also think of this pain as sensory feedback from the injured muscle telling us something is wrong. Now, here is another important piece of info. Now, as your injured muscle is sore because of the inflammation and the chemicals that are released in high amounts during inflammation, your muscles are not only sore, but you can experience sharp, immediate pain if you somehow perturb that sore muscle. For example, you strain your quads, and you have extremely sore quads a day later because of the inflammation. Say you try to contract your injured quads, you know that you would experience very sharp pain telling you to stop doing that. So why, in addition to soreness, do we have sharp pain when we actually perturb the injured sore muscle? Well, that is due to the fact that with inflammation, there is increased sensitivity of mechanoreceptors on those nociceptors. In other words, the mechanoreceptors have a lower threshold for mechanical stimuli to be noxious. So mechanical changes in the muscle, like when you stretch or contract, that normally do not cause pain, will now cause pain because the mechanoreceptors on the nociceptors are much more sensitive to that stimuli. And this is again caused by the inflammation. Again, this is for the same underlying principle of protecting the muscle from an overload stress, excessive tension. So in summary, to connect everything together, With greater severity of strain, you have greater acute inflammatory response, which means you have greater recruitment and presence of inflammatory cells, which means you have greater release and thus presence of inflammatory chemicals and free radicals, which means these chemicals can be noxious stimuli, which means you have greater activation of nociceptors, which means you have greater nociception, which means you have greater degree of pain. This is why the level of pain is directly correlated to the level of strain severity. And why do you think fundamentally there is more pain with greater injury? Well, let's go back to the fundamental purpose of pain. It is to protect the injured muscle. So the fundamental reason as to why there is greater pain with greater injury is because there is a greater need for protection since a lot of healing needs to be done. And the muscle is extremely vulnerable to re-injury if tension or some perturbation is applied. So one of the beauties of this biological mechanism is that it is so well coordinated and purposeful. Imagine if there was no pain. Yeah, that sounds great on the surface, but don't you think that would enable you to use your injured muscle, especially for athletes, a muscle that is extremely vulnerable? Without pain, muscle or any tissue for that matter that has undergone injury will likely not heal properly since there's nothing to avert you from applying the thing that injured the muscle in the first place, which is tension. So all you would be doing without pain is continuously damaging the muscle. This is why there are controversies associated with some pain medications, such as opioids, which block nociception signals from reaching the brain. This is a very important topic I will discuss in the next lecture series, where we will discuss the dangers of treating pain as opposed to treating the injury. Another controversy in sports medicine is the use of modalities to reduce inflammation extensively as a primary target of intervention, of pain intervention. More specifically, I'm talking about modalities to block some of these inflammatory chemicals, particularly those that can be noxious stimuli. I am alluding to the use of NSAIDs, non-steroidal anti-inflammatory drugs. Now, the reason why they are controversial as quote-unquote treatment is because they block the chemicals that can cause pain. These very same chemicals are those that set the foundation for repair processes, as I emphasized earlier. They also stimulate repair processes, as you will see in the upcoming slides. Always remember, in the context of a muscle strain, pain is supportive of healing since it protects the muscle. So it makes sense that the factors that stimulate pain, like inflammatory chemicals and free radicals, for example, also stimulate healing. So by blocking these factors, you may reduce pain but compromise or delay repair. Now, I also mentioned that controlling excessive inflammation is also an important factor of acute treatment. So there is some complexity to controlling inflammation. How much is too much and how much could compromise repair? More on this paradox and controversy surrounding anti-inflammatory modalities in the next lecture. I just wanted to set the groundwork for that lecture. All right, so now let's move on to the next phase, which is the repair phase, which begins roughly around 2 days post-injury. And again, as a reminder, this all depends on the severity of the strain. Now, one important fact you must understand is that these phases, particularly the destruction and repair phases, generally overlap one another to some extent, in that the acute inflammation overlaps with the beginning of the repair phase. And this is because the chemicals released during inflammation are responsible for clearing the regeneration and central zones. They are also, as emphasized multiple times, responsible for initiating the process of repair. So first, let's define repair and what it comprises of. Repair is just a general term, but there are two processes of repair that are supportive and competitive at the same time. These two processes of repair are differentiated by the type of healing they provide. One process of repair is regeneration, which involves the reconstruction of the damaged segments of the muscle fiber to restore the muscle fiber back to its original shape. Regeneration is described here as both functional and structural healing. It is functional healing because regeneration results in the restoration of muscle fiber function, which is to contract. During regeneration, all the elements within muscle fibers responsible for contraction are being rebuilt. These include elements such as the myofilament proteins, the sarcomere structure, and so forth. Regeneration is also structural healing because it improves the structural integrity of the damaged fiber. Structural healing through regeneration is achieved by resynthesizing all the structural proteins and reconstructing all the structures, like within the sarcomeres, for example, that are required for the muscle fiber to have structural integrity. The other process of repair is fibrogenesis, specifically scar tissue formation. Fibrogenesis is the process by which fibrotic tissue, such as connective tissue, is formed. Again, in the case of muscle strain, we are talking about a specialized connective tissue called scar tissue. Scar tissue is also referred to as adhesions. This is not to be confused with the term adhesion complexes, which are used to describe costomeres. Scar tissue as a connective tissue is intended to adhere the wounded muscle tissue/cells together. Technically speaking, scar tissue forms in the central zone in between the fiber stumps to keep the ruptured muscle fiber intact. Scar tissue formation via fibrogenesis is described only as structural healing and not functional healing. Why do you think it is not functional healing? Well, it is because scar tissue is not muscle tissue. It does not contain any contractile elements like muscle. In other words, it has no ability to contract, and therefore it does not help restore, at least directly, the contractile function of injured muscle. However, scar tissue provides healing through solely structural support. Therefore, scar tissue formation during the repair phase only provides structural healing, and this is through an entirely different mechanism than regeneration. Regeneration provides structural healing by reconstructing the actual structures of muscle fibers that were destructed during the injury, while scar tissue simply provides a connection between the ruptured ends of the muscle fiber. In other words, a bridge between the fiber stumps. And of course, we will discuss the mechanism by which both regeneration and scar tissue formation are initiated just in a bit. Now, you must keep in mind both regeneration and scar tissue formation are concurrent processes for the ultimate sake of healing. Scar tissue formation occurs at a faster rate than regeneration, and thus, after injury, usually around 2 days post-injury, the damaged muscle will present with scar tissue before regenerated fiber segments. And this is naturally occurring as scar tissue essentially acts as a band-aid to keep the muscle fibers and thus tissue intact while regeneration proceeds. However, fibrogenesis and regeneration are also competitive processes in that the ratio between these two processes can dictate the quality of healing. Obviously, the goal for optimal recovery is to have greater regeneration to scar tissue formation ratio, since we want to achieve both functional and structural healing through the reconstruction of muscle. This would be the route to restoring strength and performance, since again, scar tissue only provides structural healing and not functional. Having more scar tissue formation versus regeneration, a condition known as fibrosis, can lead to poor quality healing in that functional healing is compromised, since this gap created by the rupture or the wound gap is more so filled with non-muscle tissue. It is filled with connective/scar tissue. Thus, the balanced progression between regeneration and scar tissue fibrogenesis remains critical for the optimal recovery, especially for athletes who need to restore function and performance to return to sport. Either way, whether it is through greater scar tissue formation or greater regeneration, the muscle will heal. The question is rather the quality of healing that you will achieve. So in summary, the goal is to achieve a greater regeneration to scar tissue formation ratio. This means acute treatment and rehabilitation modalities are fundamentally designed to facilitate regeneration while minimizing excessive scar tissue formation, aka fibrosis. I already alluded to some of the acute treatment strategies earlier that are intended to minimize this gap between the fiber stumps by reducing hematoma and excessive degradation through excessive inflammation. By minimizing this wound gap, there is less need for abundant scar tissue to keep the ruptured ends together. And as I said, we will discuss this mechanism of acute treatment in addition to rehab modalities in our upcoming lecture series. In other words, we will address the question of how we can improve quality healing in athletes after a strain by facilitating regeneration and minimizing fibrosis. Okay, so now that we understand the basis of repair and the two healing processes with the repair phase, let's discuss the mechanism by which regeneration and scar tissue formation are initiated. So, first of all, as we know, the prior phase involved inflammation and the recruitment of inflammatory cells such as macrophages. In the last phase, macrophages were polarized to the M1 variety, which are programmed to mediate processes like phagocytosis and degradation. As the time proceeds, particularly around 2 days post injury, macrophages undergo M2A polarization, which programs the macrophages to initiate repair processes, regeneration, and scar tissue formation specifically. M2A macrophages also work to slow down inflammation by deprogramming M1 macrophages, thereby decreasing phagocytosis rates, degradation, and the release of inflammatory chemicals and free radicals. At this stage, inflammation is not completely eradicated, but it is just to a lesser degree. So, how do these M2A macrophages initiate repair? First, M2A macrophages synthesize and release specialized proteins called growth factors, which are critical for wound healing. They are responsible primarily for cell differentiation, which is a process by which cells are converted to more specialized cells. More on this in a bit. Growth factors also stimulate anabolism, which is the opposite of catabolism or degradation. This describes metabolic processes or reactions that result in the construction or synthesis of large molecules, such as muscle proteins and collagen, for example. One of the major growth factors released by M2A macrophages include transforming growth factor beta, or TGF beta for short. TGF beta, upon its release, interacts with respective receptors which are highly expressed on the membranes of fibroblasts. Fibroblasts are a type of cell that synthesizes connective tissues and ECM. In particular, it is the major manufacturer of collagen proteins and thus collagen fibers. In other words, fibroblasts perform fibrogenesis. So once all these TGF betas released from M2A macrophages bind to its receptor on resident fibroblasts, these fibroblasts undergo differentiation, which I defined earlier as the process by which a cell becomes a more specialized cell. In this case, the fibroblast becomes myofibroblasts, which are fibroblasts that specifically are involved in wound healing, mainly through scar tissue formation. So as a multitude of fibroblasts differentiate into myofibroblasts, fibrogenesis ramps up and scar tissue begins to form. So where does the scar tissue form? Well, it would make sense that it forms in the middle of the tear, in the central zone. The central zone is, at this point, the weakest point of the muscle and muscle fibers, since this is the middle of the rupture. This is the center of the wound gap and thus susceptible to further tearing if overloading tension is applied. Therefore, it will make sense that some type of adhesion is applied to this area. That adhesion, again, is scar tissue. Remember, the central zone used to contain the hematoma and the blood clot. During inflammation, macrophages remove the blood clot. Now, this area is being filled with scar tissue, which is primarily made up of stiff collagen fibers, which are disorganized in nature. And as I mentioned earlier, the scar tissue serves as an adhesive, hence its description as an adhesion. But if the central zone is flanked by regeneration zones where at this point contain nothing, how does the scar tissue adhere the ends of the opposing fiber stumps together? Remember, in the prior slide, I mentioned that during the destructive phase, the basal lamina remains unperturbed in the regeneration zone. And this is because they serve as the scaffolding for muscle fibers to regenerate on. Well, the ends of the basal lamina, that protrudes into the central zone is what initially adheres to the scar tissue. Remember, the basal lamina is made up of a fine mesh of light collagen fibers, and in this situation, the collagen fibers in the basal lamina ends within the central zone simply intertwine with the collagen fibers of the scar tissue. This, at least initially, allows for adhesion at the rupture site. So as fibrogenesis and scar tissue formation persists and this scar tissue begins to widen, you have regeneration occurring within the regeneration zones. So how does regeneration start? Like with any process, there needs to be a signal. Although there are multiple signals involved in the initiation of regeneration processes, the major one involved is a growth factor called IGF-1, insulin-like growth factor 1. There are several sources of IGF-1 during the repair phase. First, the macrophages, both the remaining M1 and the new M2A macrophages release IGF-1. Also, the muscle fiber itself releases a variant or isoform of IGF-1 called MGF, mechanogrowth factor, also labeled as IGF-1EC isoform. The IGF-1 released from macrophages works in a paracrine fashion, which means IGF-1 is released and interacts with other cells in close vicinity, so it doesn't go into blood circulation and travels far distances. It travels only a very short distance. MGF, on the other hand, works in an autocrine fashion, which simply means that it interacts with the very same cell that it is released from. Either way, IGF-1 is stimulatory to the activation of muscle-specific stem cells or muscle progenitor cells called satellite cells. And you can see them illustrated here as small mononuclear cells sandwiched between the sarcolemma and the basal lamina. Stem cells are undifferentiated cells, and they are used primarily to regenerate specific cells. In this case, the satellite cell is going to be used to make muscle fibers, or at least portions of an existing muscle fiber. So what happens next? So between 2 to 3 days post-injury, satellite cell activity is elevated. Also keep in mind other stem cells are involved, such as mesenchymal stem cells, which are derived from bone marrow, as well as muscle-derived stem cells. But we will focus mainly on satellite cells because there is much more substantial evidence concerning their role in muscle repair. So when satellite cells are activated upon stimuli from such things as IGF-1 or MGF, the initial process is satellite cell proliferation. In other words, the satellite cell multiplies as illustrated here. Now, some of these are used to renew the satellite cell pool that is dormant underneath the basal lamina, but most of them become or differentiate into myogenic progenitor cells, or myoblasts for short. These are cells that are precursors to muscle cells, and as you can see, they are all individually myonuclear cells. Remember, muscle fibers are multinucleated, so this should tell you that myoblasts are not functioning muscle cells yet, but they are committed to becoming mature, fully functioning muscle fibers, or part of the existing muscle fibers, as in this example. Now, while all this is occurring in the regeneration zone, scar tissue formation continues within the central zone to further reinforce the structure of the muscle fiber. All right, so roughly 5 days post-injury, myoblasts begin to fuse together to form something that resembles a muscle fiber, at least in structure. These fused myoblasts form myotubes, which are essentially baby muscle fibers that are multinucleated, just like an adult muscle fiber. As myoblast fusion progresses, myotubes form and accumulate within the regeneration zones. And remember, the basal lamina is the scaffold on which muscle fibers regenerate. So these myotubes begin forming along the basal lamina first. Within the myotubes, there is an increase in anabolic processes, which I mentioned describes metabolic processes that build large molecules or synthesize large molecules. So what do you think are being constructed within these myotubes, for example? In order for the myotube to mature into a functioning part of the muscle fiber, all those contractile and structural proteins must be synthesized in order to restore function so it can produce contraction. So one of the major anabolic processes that occur during the repair phase is myofibrillar protein synthesis. Myofibrillars, again, are the strands within muscle fibers that contain the myofilaments packaged into individual sarcomeres. So myofibrillar protein synthesis is simply the synthesis of proteins that belong in the sarcomeres. As anabolism occurs within each myotube, they mature and begin to form into existing muscle fiber. Now, during this time, scar tissue has become denser and stronger, providing good structural support for the muscle fibers under repair. Also, keep in mind, this is around the time when inflammation begins to resolve, and there is a shift from pro-inflammatory to an anti-inflammatory status. This is partly mediated by the M2, B, and C polarized macrophages. So these macrophages are programmed to essentially inhibit the M1 pro-inflammatory macrophages. It deprograms these macrophages. You can think of the M2B and C as anti-inflammatory macrophages. Now we enter the final stages of the repair phase, where regeneration has progressed to the point where mature functioning myofiber segments have filled the majority of the regeneration zones and have extended the fiber stumps of the surviving zone inward towards the scar tissue in the central zone. Branches of the regenerating muscle fiber on both sides of the central zone begin to pierce through the scar tissue in efforts to reduce the scar tissue and to interlace the two fiber stumps together, creating one whole intact muscle fiber back to its original state. However, as time passes, the fiber can only extend far enough before regeneration ceases. At this point, the fiber ends form a connection with the scar tissue through adhesion complexes, which again are those transmembrane proteins called costomeres. In other words, new mini MTJs are formed between the two fiber stumps and the scar tissue in the middle. At this point, the fiber stumps will not interlace and the scar tissue will remain as a permanent structure within this MTU. This circumstance is especially relevant to high-degree strains that are characterized by severe rupture or tear and large wound gaps, meaning the central and regenerating zones in between the surviving zones is very wide. Thus, there is a large space to be filled. And since I said fibrogenesis exceeds the rate of regeneration, a large amount of scar tissue will form to fill that large wound gap. This again is to reinforce the muscle structurally. Because of the excess scar tissue that has formed, especially with high-degree strains, the regenerating muscle fibers on each side of the scar tissue have very little chance of reconnecting because of the length of time it takes for that to occur. So usually with severe strains, the scar tissue does not reduce completely. Instead, the fiber stumps on both sides of the scar tissue adhere to it with costomeres, and mini MTJs are formed. With exercise-induced muscle damage and maybe light strains, scar tissue can usually reduce to a minimum or be completely replaced by the muscle fiber. And to compare this to what you observe in the skin when you accidentally cut it, you know that the hematoma eventually clots. Then the clot is replaced eventually with scar tissue, which presents itself as a whitish tissue that is discolored in comparison to the skin tissue. The scar tissue fills the wound gap to adhere the two sides of the wound together. Now, as we know, the skin will eventually replace the scar tissue if the scar tissue is minimal. However, with larger wounds in the skin, with larger amounts of scar tissue, it is rare for that large scar tissue to be completely reduced down to a minimum and to be completely replaced by skin tissue. This same concept applies to muscle. The larger the tear, the larger the wound gap. This means the greater need for scar tissue and a decreased chance for the scar tissue to be fully replaced by muscle tissue. And this leads to the creation of more mini MTJs, which I alluded to earlier, are weak points in the MTU and susceptible to tension-induced damage, particularly exercise-induced muscle damage. Here we have another visual of what I just discussed. Here we have what appears to be two fibers separated by connective scar tissue. However, prior to its rupture during the strain, this was one single fiber. Through the repair process, fibrogenesis was increased to form this scar tissue to adhere the fiber stumps together, thereby closing the wound gap as the fiber regenerates. The fiber stumps on both ends of the scar tissue pierce through the scar, reducing the scar tissue while the fiber stumps attempt to reconnect. However, especially during severe ruptures and large wound gaps, scar tissue formation becomes excessive, and therefore a greater amount of regeneration is required to fully interlace the extending fiber stumps. In this case, oftentimes, the fiber stumps eventually stop regenerating and form a connection with the scar tissue through costomeres, aka adhesion complexes, as shown in this figure. This in turn results in the formation of new mini MTJs. Remember, as we discussed earlier in this lecture, mini MTJs normally exist to connect individual muscle fibers in series with ECM material in between. In this case, instead of ECM material, it is dense scar tissue, which unlike the ECM are not very good force transmitters. So for this one single fiber, which is now split by scar tissue, its incorporation in the MTU would be summarized as such. It would go from tendon to MTJ to muscle fiber to mini MTJ to scar tissue to mini MTJ to muscle fiber to MTJ to tendon. Of course, this is a very simplified description, but nevertheless, you can understand conceptually what is happening when scar tissue remains. Now, as I described earlier, the mini MTJs are also weak points in the MTU and is susceptible mostly to muscle fiber damage, like following unaccustomed exercise, aka EIMD, exercise-induced muscle damage. This essentially means that the greater presence of unresolved scar tissue, the more mini MTJs in a given MTU, and thus the MTU overall becomes structurally and functionally weaker. And this is why acute treatment and rehabilitation modalities are fundamentally centered on facilitating regeneration and minimizing excessive scar tissue formation, aka fibrosis. By doing so, you have better quality healing in that you have a greater regeneration to scar tissue formation ratio, and thus greater structural plus functional healing, as opposed to just structural healing through connective scar tissue. The presence of permanent scar tissue within the MTU is also a common feature in aging athletes. And this is because the amount of damage and injury the athlete has likely experienced throughout their athletic career. So over time, as scar tissue accumulates and more mini MTJs are formed, their MTU, more so their muscle, is now more fibrotic, which means muscle cells have been replaced by connective scar tissues. And as we know, scar tissue does not directly contribute to contraction, as it does not contain contractile elements to produce it. Thus, as a result, over time, the MTU has a decreased strength capacity. And this is one of the multiple factors that contribute to the reduced muscular capacities and performance of aging athletes. And this is also contributing to the increased rate of muscle damage and increased susceptibility to muscle strains with aging. Again, because there is just much more weak points within the MTU. So as the muscle is undergoing repair and regeneration and fibrogenesis is active, there are other tissues critical for restoring muscle function that also needs to undergo regeneration. For example, as we discussed earlier, one of the factors that contributes to functional declines following a strain is motor neuron denervation. And I discussed what is illustrated in the top figure. Now, as the muscle undergoes repair, so do denervated or severed motor neurons. On the adjacent side, denervations occurred in the regeneration zone, while the damaged fiber segments were being necrotized. And with that, the neuromuscular junction, which is again the connection between the motor neuron and the fiber, was destroyed. So as the fiber segments within the regeneration zone regenerates, the neuromuscular junction can be reconstructed, and motor neurons can be reinnervated. Of course, this would also involve the process of motor neuron regeneration, a process referred to as neurogenesis, formation of neurons. So, like all the processes we've discussed in this lecture, neurogenesis requires some type of signal to be initiated. The major source of this signal comes from chemicals called neurotrophic factors, which are largely released by muscle stem cells like satellite cells. It is interesting that as these stem cells are involved in regenerating muscle, they are also aware of the fact that motor neurons must be regenerated as well. Some of the prominent neurotrophic factors include brain-derived neurotrophic factor, or BDNF, which obviously is derived from the brain but also from the muscle as well. There is nerve growth factor and ciliary neurotrophic factor, as well as neurotrophin 3. Now, with severe strains, full reinnervation may not occur, and this is mostly related to neurons that innervate the muscle fibers on the adjacent side. So, oftentimes, full reinnervation does not occur, especially with high degree strains, particularly due to excessive scar tissue formation, or fibrosis. Neurons have difficulty regenerating through scar tissue. This is mainly due to two factors. One, scar tissue is very dense, and there's not a lot of channels for neurons to run through. Secondly, scar tissue has very poor blood perfusion. Scar tissue has poor vascularity and thus poor blood supply. In order for neurogenesis to occur, or for even neurons to function properly, there needs to be proper blood supply, which the area within the scar tissue does not provide. So in summary, along with muscle regeneration, you have neurogenesis to reestablish motor neuron innervations, to restore muscle function and strength. What other types of tissues do you think require regeneration? Blood vessels, particularly micro blood vessels called capillaries, that supply the muscle with blood also regenerates. This is a process called angiogenesis. Blood vessels have a really good regenerative capacity, so this usually precedes muscle regeneration as well as neurogenesis. So now going back to scar tissue, I want to discuss the consequences of fibrosis or excessive scar tissue formation. As with acute inflammation, I mentioned earlier that scar tissue formation is also a necessary evil, and is more so evil when it is excessive, or in other words, there is fibrosis. As I indicated earlier, fibrosis can happen with large wound gaps, such as during a high degree muscle strain. Fibrosis can also occur even with lighter strains when proper acute treatments and rehabilitative modalities are not implemented. For example, with improper acute treatment and care immediately following injury, excessive hematoma and inflammation could widen the wound gap, increasing the chance for fibrosis. With improper rehabilitation, for example, fibrosis can occur with re-rupture of the wound due to premature excessive loading or poor facilitation of regeneration by not properly loading the muscle at all. Now, the consequences of fibrosis during a muscle strain can be categorized as functional, structural, and biochemical effects. First, the functional effects of fibrosis. These include 1. Lateral and longitudinal force transmission compromised. Remember, lateral force transmission is mediated through the ECM and allows for force distribution across the MTU. When ECM is replaced by scar tissue, this lateral force transmission is impaired. The reason being is that the collagen matrix of the ECM has a lot to do with force transmission efficiency. Scar tissue's collagen matrix is unlike the ECM. It is made up of dense collagen fibers in a disorganized matrix that is not at all conducive to force transfer. Also, because of the physical characteristics of scar tissue, there is compromised longitudinal force transmission across the length of the muscle fiber towards the tendon. When scar tissue forms, a single muscle fiber is essentially split into two in series, with dense scar tissue in the middle as opposed to ECM. Therefore, as the muscle fiber contracts, there is insufficient force transfer across those two fibers separated by the scar tissue. Again, because the scar tissue and its collagen matrix is not ideal for force transmission. Second, fibrotic scar tissue is essentially replacing muscle tissue, which means there will be reduced contractility of the MTU overall, since as I emphasized earlier, scar tissue is connective tissue, not muscle tissue. It does not contain any contractile components. Third, the overall quality of the muscle architecture is reduced since now there is an increased fibrotic to muscle tissue ratio. In muscle, we obviously want more muscle and less non-muscle tissue within it. And lastly, going along with that point, we talked about denervations associated with scar tissue. And also, one factor I did not mention earlier is that existing nerve fibers caught in the scar tissue matrix may undergo irritation due to impingements, and also due to poor blood perfusion around the scar tissue. Remember, I mentioned scar tissue has very little blood supply since microvessels tend not to form around scar tissue. As for the structural effects of fibrosis, we began this discussion in detail a couple slides ago. Remember, as scar tissue becomes permanent, the regenerating fiber stumps adhere to the scar tissue via costomeres, thereby forming new mini MTJs. This again creates further weak points within the MTU and causes greater susceptibility to muscle fiber damage and possible future strains. In other words, fibrosis reduces not only the functional strength of the MTU as indicated in the last bullet, but also the structural strength. As for the biochemical effects, as I said, the area within and around scar tissue is underperfused due to low microvascularity. Because of the poor blood supply, there is poor oxygen supply, especially within the fibers around the scar tissue. This means that those muscle fibers rely heavily on non-oxygen requiring energy pathways, also known as anaerobic pathways or anaerobic metabolism. This therefore means that there is a very low aerobic capacity in those muscle fibers. When those muscles contract and expend energy via anaerobic metabolism, there is a tendency of increased acidosis. This occurs because of the accumulation of positive hydrogen ions, also known as simply protons. This usually occurs normally during very high to max intensity exercise and is the cause of fatigue and sometimes pain like the burning we often experience when we lift weights. But in these underperfused fibers around the excess scar tissue, even at rest, acidosis can occur because of poor blood and therefore oxygen supply. This can lead to pain as acidosis, more specifically protons when accumulated, are a known noxious stimuli. And we hear this often with athletes who have constant pain. Of course, it can be due to multiple issues, but one may perhaps be the underperfusion and acidification of muscle fibers around fibrotic scar tissue. Another indirect consequence of reduced structural integrity is chronic inflammation, which I said was abnormal. With reduced structural integrity at the scar tissue and mini MTJ sites, there is a greater risk for damage, as I mentioned. And with that, the MTU is more susceptible to exercise-induced muscle damage, especially in an athlete who trains or plays sports quite frequently. With repeated damage, there is a repeated cycle of all the steps we discussed in this lecture, including the destructive phase and the associated inflammation. Thus, the muscle can be under a state of chronic, perpetual inflammation due to the repeated damage to those sites. This may result in pain and possibly muscle degeneration over time. Now, continuing on with the final phase, we have the remodeling phase, which generally occurs 14 to 21 days post-injury. The remodeling phase is just as the term implies. The muscle fibers undergo heavy remodeling of its intracellular components. This includes organelles like the mitochondria, the sarcoplasmic reticulum, the sarcolemma, the transverse tubules, and also the myofibrils and all the myofilaments within it. All of these components are required for muscle fibers to function, for it to contract. Also during this remodeling phase, the ECM is reconstructed, also through the process of fibrogenesis. So yes, this involves the activity of those myofibroblasts. During the remodeling phase, around day 21, the fiber stumps begin to interlace, as you can see in this figure, as long as the scar tissue is minimal and there's no presence of fibrosis. This usually occurs with light strains or EIMD situations, but not high-grade strains. With high-grade strains, as I indicated, due to the large wound gap, scar tissue would remain as the fiber stumps form mini MTJs with the scar tissue. At this point, the athlete is well into their rehabilitation. And because the muscle fibers have regained structural integrity and is not so vulnerable to a re-rupture, the athlete can adequately overload the muscle to help restore strength. In other words, the athlete can undergo strength training. At this point, strength training is one of the most critical interventions in a rehabilitation program. Now, a common question that comes up is how scar tissue can be removed. We hear about all these manual therapies that claim to remove or quote unquote break up scar tissue. Let me just say simply that you cannot do this through any manual intervention. The only way you could technically break up scar tissue is by re-rupturing the site of prior injury where the scar tissue has formed. Scar tissue is not some loose material that you can easily remove or break apart. Think about scars that form on your skin. Do you think those are easily removed by applying some type of manual therapy on them? No. The only way you would be able to remove that scar is by cutting it out, which would worsen the issue because now that site would go through the process of injury and repair, probably resulting in more scar tissue formation. So anytime you hear anyone, whether they are a professional or not, say anything to the effect of some modality being able to break up scar tissue, you should definitely question their credibility and knowledge. Scar tissue is made up of very similar materials as tendons and ligaments. If you claim that some manual therapy breaks up scar tissue, then you are also claiming that applying those same therapies to the tendon or ligament would also break up those tissues, which obviously won't be favorable. I think it goes without saying that there is not one manual therapy examined scientifically that has shown to reduce scar tissue. None of it is evidence-based claims. Now, this does not mean those manual therapies do not help. They surely do, to some extent. They may especially help with mobility and temporary pain relief, but it is not at all an effect of scar tissue removal. It is through some other mechanism, which we will describe in the next lecture. All right, so with that said, what is the only thing that can technically remove scar tissue? It's the natural process of muscle regeneration. That is what reduces scar tissue. So it is imperative to apply therapies that can facilitate regeneration during rehab. This can range from non-pharmacological to pharmacological approaches, with the former being more practical than the latter, of course. In our next lecture, we will discuss rehab modalities and what types of evidence-based interventions are implemented to facilitate regeneration, to minimize fibrosis and permanent scar tissue formations. We will also talk about acute treatment strategies to minimize the chance for fibrosis by decreasing the wound gap. And as a summary of all three phases, from the destructive to the remodeling phases, here is a nice summary for you to use to check your understanding, and another visual in addition to those I provided in the PowerPoints to help you understand the overall process. And leading into our next lecture series on rehabilitation and therapy, we have some key principles here. First, rehabilitation strategies should focus on increasing the regeneration to scar tissue formation ratio to reduce fibrosis and improve quality of healing. Second, prevent formation of dense scar tissues. It's hard to get rid of biologically speaking. So it is best, especially with severe injuries, to minimize scar tissue formation as much as possible. And one way to do this, as I alluded to earlier, is by implementing strategies early on to reduce the wound gap. And some questions that we will answer is pain management regenerative therapy? Of course, the immediate answer to that is no, but we will discuss this in much more detail. And we also want to discuss the inflammation paradox, more specifically the anti-inflammation paradox, to control or not to control inflammation. I alluded to some of those points earlier in this lecture. So we will talk about the use of NSAIDs, and we will discuss the question of how much is too much when it comes to controlling inflammation through acute treatment strategies, especially when there is a severe strain and excessive inflammation. We'll talk about the exercise paradox, and of course, more details in the next lecture. And to outline the contents of our next lecture, we will go over the classifications and diagnosis of muscle strains, predisposing factors of muscle strains, acute treatments for MTU injuries, particularly muscle strains, and the mechanisms of action. So this is what you would do immediately after the injury. We'll talk about some of the principles and some of the newer principles that have been developed with the scientific evidence. We'll talk about, again, the anti-inflammatory paradox in sports medicine and some controversies associated with anti-inflammatory modalities like NSAID use. We'll talk about physical rehabilitation, and this is usually through the repair and remodeling phases. We will discuss mainly exercise-based therapies and the mechanism of action of those exercise-based therapies in promoting rehabilitation and quality healing
through regeneration. We'll talk about exercise-based prehabs. Can you preemptively promote a greater regeneration to fibrogenesis ratio? And that will be the fundamental question there. We'll talk about something called the exercise paradox. Then we'll go into regenerative therapies. And the two that I would like to talk about, because it is sort of emerging within the scientific literature in sports medicine, is platelet-rich plasma therapy, or PRP, and direct stem cell therapy, more specifically mesenchymal stem cell treatment. We'll talk about the literature in the science regarding these two regenerative therapies and the mechanism underlying its potential effects. We'll talk a little bit about therapy myths and do some myth busting. We'll talk a little bit about exercise-induced muscle damage and just general recovery. And there will be some minor topics included as well.